Assalamualaikum, this is Dr. Noman. Nowadays, I read eye pathology for the purpose of general practice. So I'm sharing my knowledge with you. Hopefully, it will work for you. So in eye, starting from the outer sides, if there is any small dots around the eye that are called milia, it is actually the problem of skin, not the problem of eye. So reassure the patient that there is no problem with the vision and he can go for his skin specialist. It is the actually the collection of some sebaceous fluid gland accumulation in the skin. So and now moving towards the eyelid, if there is the inflammation of the eyelid, that is called blepharitis. Blepharitis, if there is bacterial suspicion of bacterial infection, definitely you can prescribe an oral antibiotic. One thing we must clear, blepharitis infection of the eyelid is basically skin and not the infection of the eye. So oral or the topical creams for the eyelid is the choice, not the eye drops. So if there is infection of one eyelash, that is called stye. So stye is also the problem of skin, and basically advise the patient for warm presses. So there is a mouth for the collection of the pus, and it can be drained or it can be ooze out easily. And you can prescribe topical cream on that side of on that eyelid, as well as you have to pluck that eyelid, and it can most of the time lead to the formation of mouth for the drainage of the place for the drainage of pus. And you prescribe oral antibiotics or the topical cream on that place, and no need of the eye drops in stye. And then comes the lesion. Lesion is actually collection the glandular substance in that is formed from Niobium glands, and lesion can a collection of this fluid in lower eyelid or in the upper eyelid. It is most of the time benign, but if it is obstructing in the vision, you can refer it to the patient for the treatment of it. And lesion can also get infected, and in this case you have to prescribe antibiotics to that patient. Now coming towards the inner structure of the eye, the problems are before the involvement of the sclera. Episcleritis. Episcleritis usually the redness blench with the compression, while if the sclera is involved, scleritis, it don't blench. And scleritis is usually is the more severe infection, and you have to refer to the patient to the eye specialist. It can, because it can involve the further eye structures, but it is not the problem with the episcleritis. In episcleritis, you have to prescribe antibiotics to the patient. And now coming towards the conjunctiva. Conjunctiva is a transparent layer on the sclera. Conjunctivitis can be bacterial, viral, and allergic. Bacterial conjunctivitis can be treated with the antibiotics, drops, ciprofloxacin, and you have to start with chloramphenicol drop. Then if severe infection, you can go for gentamicin if gram-negative infection, tobramycin tobrax for gram-negative infection, cumic levofloxacin drops, gentamicin drops, amoxicillin drops in severe infection. And now coming towards the viral conjunctivitis. Viral conjunctivitis is acute onset, and it can be spread with the hands, and it has there is most of the time reassurance and ask the patient to instill some uh, things, some refreshing thing for the eye, and because it can resolve within 10 to 14 days automatically, but it is contagious. It can spread with hands from one person to another. So it is advised, if a school going child is suffering from viral conjunctivitis, off from the school for few days is recommended. And then and reassure patient it will resolve with 10 to 14 days. Allergic conjunctivitis can there is a specific like cobblestone appearance of papillae in the inner portion of the eyelids. And allergic conjunctivitis can be treated with oral and topical drops, antihistamines. And but if it is recurrence is common, then you have to you have to go for chromoglycan drops in eye. Chromoglycan drops treatment is for 3 months, and this is allergic conjunctivitis is the variant form of hay fever. So chromoglycan is a mast cell stabilizer. So after conjunctivitis in cornea, there can be corneal ulcer, abrasion from traumatic injury. Actually, cornea don't have blood supply, so it gives nutrition from the surrounding. So if there is the problem of the cornea, and the thing you have to do corneal abrasion or ulceration, you can prescribe antibiotics to the patient, because there is no blood supply, there is no WBC to compete if there is a superior infection. So prevent bacterial infection, you can prescribe antibiotics, topical antibiotics, drops of antibiotics to the patient to avoid any bacterial infection. Okay, keratitis is the inflammation of cornea. To differentiate the keratitis from this synovitis, keratitis, in keratitis there is hazy VN, blood VN, and it is painful. I have to differentiate keratitis from conjunctivitis. In keratitis, hazy blood VN with pain, and while in conjunctivitis, eye globe don't have pain, and VN will be intact. So a physician, family physician, must differentiate these two problems. Keratitis is a more dangerous problem as compared to conjunctivitis. So after cornea, we can the further structure of the eye is anterior and posterior chamber, and you are familiar, anterior chamber is further divided into anterior compartment and posterior compartment. So in anterior compartment, if there is a problem with the drainage of aqueous humor, as aqueous humor is drained from canal of Schlemm or uvesicular junction, mainly from canal of Schlemm. If the lens get attached with cornea, there is obstruction of that angle, so there is a production of aqueous humor, but no drainage. That can leads to pressure in the increase in intraocular pressure, and acute angle glaucoma is an eye emergency. If you experience a patient with acute angle glaucoma, the things a physician can do, the strategy includes the stamps, lie the patient in supine position. As for supine position, T for timolol drops, A for acetazolamide drops, M for mannitol drop, and P for pilocarpine drops, and ask him to visit immediately to the eye specialist. Uh, in glaucoma, a general practitioner initiate the therapy and ask the patient to visit the specialist. And the symptoms of glaucoma, acute angle glaucoma, include painful eye. Vision is so disturbed that patient only can count fingers, and there will be nausea and vomiting, and pain, disturbance of vision, nausea and vomiting, and tender eyeball. These are the problems with acute angle glaucoma. In chronic glaucoma, there is no angle is not problem, and the drug therapy includes again the beta blockers that decrease production timolol, and then carbonic anhydrase inhibitor, diuretic acetazolamide that decrease production of aqueous humor, and then the drugs that increase the drainage, like latanoprost, prostaglandin and analog, that increase the drainage of aqueous humor from uveal junction, uvesicular junction, and then pilocarpine, cholinergic drug that increase the drainage from canal of Schlemm. So these are the drugs in chronic angular glaucoma, and then after glaucoma, the problems of iris includes cataract. Cataract can be age related or due to trauma or any surgery or the use of the steroid. One thing I have to told you that as a general practitioner, you are not authorized to use steroid in the eye. Use of the steroid can lead to severe clinical problems, including the cataract itself, macular degeneration, retinal detachment, and a lot of other big problems. And it can also convert the small problem into big problems. So always remember, never use as a general practitioner to topical steroids, steroid installation in the eye. In quackery it is a common practice, but as a general practitioner you are not allowed, and be aware of this situation. And these are the actually the eye specialists that are authorized to prescribe steroids to his or her patients. Okay. And cataract, there will be hazy vision. In cataract, basically meiosis, light is painful for the patient, because meiosis, there is a contraction of the iris, and that is photophobic, painful for the patient. So patient feel pain when he comes in the light. But in glaucoma, actually it is the mydriasis that leads to the more closure of the angle. So in angle closure glaucoma, mydriasis, darkness causes the more pain for the patient, while in uh, cataract, meiosis causes the problem for the patient. Okay, fine. And then comes towards uh, other problems of the eye that I forget to tell, include inward eyelid, that is entropion. For entropion, the few things a general practitioner can do. He can apply the tape to lower eyelid, so the eyelid that is disturbing the eyeball is now far away, and he can and the patient has the time to visit eye specialist. And if only few inward eyelids decate masses, then you can pluck it, but advise to refer to the patient to the eye specialist. Acropion is if there is outward movement of the eye, so there will be no the tear film will be reside in the eye. So dryness of the eye is the problem with ectropion, and it is most of the time age related. Ectropion can also be corrected surgically by the specialist. Okay, fine. Now coming towards Mm, the problems, vitamin A deficiency related problems, and that can be leads to bitter spot on the eye. So if the patient is coming, the child is coming from very poor community, vitamin A capsule, blue 100,000 units and red 200,000 units are available, and give them to the patients. Okay, pterygium is a benign lesion, and that is the collection of fibroblastic tissue on the eye. If it is away from the vein side, then you can left it as it is. But if it is involving the cornea and the vein side, then it has to remove surgically. Pancola is the similar situation, but the tissue is a scleral tissue, I think. So it is also have to remove surgically. And so these are a few other problems. And if in neonates, if you are talking, if the neonates have thick uh, secretion from the eye, it can be gonococcal secretion, and the child neonates develop it from his mother. So besides treating the children with the ceftriaxone 150 milligram intramuscularly once, you have to treat the parents with azithromycin 20 milligram per kg per day for 3 days to both parents, because these are the real person who transmitted the disease. And similarly, the neonates can also experience chlamydial infection. If one thing I forgot to tell, that if there is a chlosion meibomian gland secretion, so you have to, and it get infected, you have to treat it with the combination of metronidazole and amoxicillin, because it is not a simple skin, and meibomian gland flora is because it is related with the sinus, so it can flora can be different from the rest of the skin lesions. Okay. And coming towards the choroid is a vascular tissue, and it supplies blood supply to the surrounding. And so choroid in the posterior chamber of the eye, anterior chamber has anterior and posterior compartment, while the posterior chamber is alone, it has not further divided. In the posterior chamber there can be vitreous detachment. So flashing light is the problem in vitreous detachment. and flash light is also the sign of retinal detachment. So if the patient is experiencing flashing light, it is a painless situation. Ask the patient to visit immediately to the eye specialist to correct the problem, and it is an emergency. Macular degeneration is seen mostly in late ages, and in macular degeneration, patient complains central loss of the vision. While in retinitis pigmentosa, peripheral loss of vision is initially, then it is gradually comes toward the center. So in retinitis pigmentosa, there is tunnel-like vision. So a person can be differentiated for retinitis pigmentosa from macular degeneration. Both are the condition you have to refer to the patient to the eye specialist. And central painless loss of the vision includes central retinal artery occlusion and central retinal vein occlusion. Central retinal artery occlusion is a sudden onset, but one thing you have to remember: the onset must be sudden, not the patient has realized he suddenly realized that he has lost his vision. These are two different entities. So if there is a central retinal artery occlusion, painless loss of the vision, if there is a delay of 7 to 8 hours visit the eye specialist, then you can prescribe aspirin 300 milligram per kg per day, 300 milligram per day to the patient in antiplatelet dosage. But if there is delay of 24 hours, then there will be loss of the vision, and you can do nothing just to save the other vision of the other eye and to avoid the central retinal artery occlusion in the second eye. So it is an eye emergency. Central retinal vein occlusion is also sudden, but it is compared to artery occlusion, it is in hours. But still emergency and ask to the patient, and there are therapy available to treat it. Retinal artery vein occlusions are emergencies, and these are the problems of eye specialist. And these are painless loss of the vision. Painful loss of the vision is angle closure glaucoma. In the chronic open angle glaucoma, the drug therapy includes the same beta blockers, acetazolamide, and mannitol, pilocarpine, latanoprost, brimonidine. These drug therapies are available for the patients. And I think I am missing in this situation. I think I haven't discussed with you. Okay, huh. Viral infection, herpes infection can also involve the ophthalmic division uh, of trigeminal nerve, and trigeminal nerve also supply the cornea. So if there is a lesion that is on the one side of the ophthalmic division and not crosses the midline, definitely it is herpes simplex or herpes infection, and you have to treat it with a tablet acyclovir 300 milligram 5 times a day for 1 week. But if it is involving the tip of the nose, that is the Hutchinson signs, then it is a bigger neurological problem, and refer to the patient to the neurologist if the involvement of the tip or the side of the nose, mainly the tip of the nose involved. That is called Hutchinson sign. On fundoscopy, few things I forget. In cataract, there is no red reflex on fundoscopy. Okay, on fundoscopy, there is central retinal artery occlusion. There, the macula will be faded. The redness will be less. If there is vein occlusion, there will be hemorrhage present on fundoscopy. Okay, and this ring is seen in vitreous degeneration. Okay, flashing is the sign of if the patient experience lights flashing, then it is the retinal detachment or the curtain-like vision, and that is also the vitreous or retinal detachment. And ask patient to visit immediately to the eye specialist. Okay, any other thing I missed? I think I have cleared all of the things that I have read, and I wish that this video is hopeful for you, is useful for you. Thank you for your patience listening. Thank you. Allah Hafiz.